Good afternoon and welcome to our meeting dedicated to the project Improving Cancer Care Coordination and Screening in Slovakia. It is live streamed in YouTube channel of IARC, so you can access also the replay after the meeting there. If you have any questions on the project, please send them on the emails displayed on the screen. My name is Nadia Dimitrova. I'm Public Health Officer at the International Agency for Research on Cancer, coordinating the activities on this project, and would like to invite now André Carvalho, scientist at IARC and principal investigator, to present the project and the partners. André, please.
Thank you, Nadia, and thank you all of you that join us live today or is watching the video. It is our honor and my privilege to have participated as the principal investigator on this important project in Slovakia. I would like to express my gratitude by thanking all the stakeholders and authorities from different Slovak institutions and the government involved in this project. Also, the IARC staff, international experts that made part of the IARC team on this project, as well as the European Commission, specifically the DG Reform, for the funding. Without all of you working together with us, the project could not be taken place. I'd like to bring some background, if you can go to the next, some background regarding the project. Right, this project is started by a request from the Minister of Health from Slovakia in 2021 to the European Commission, specific to DG Reform, regarding how Slovakia could improve their cancer screening and designing, a communication strategy for cancer screening awareness in the country. Our activities were aligned with the newly launched then the Europeans' Beat Cancer Plan. We put together a coordination and management in which we had a steering committee, mainly with local stakeholders that have the policymakers, the major stakeholders that could disseminate and facilitate the implementation of the findings of this project. IARC secretary work to in between and to facilitate the discussion between the experts groups where we put together again, local experts group for cancer register, cancer screening, and communication strategies, working with experts that IARC provided from our team, from international experts, or for experts in the country. And together, we build the project. Next one, please. In the end of the day, what we are looking here, right, is how we could have been implementing a project that could contribute to improve coverage and quality of breast, cervical, and colorectal cancer screening programs, and a better awareness of stakeholders regarding screening programs in Slovakia. Please, next one, Nadia. We're going to go today, to the institutional grants from now, the cancer registration findings and what is the action plan, cancer screening findings and action plan, the communication and cancers for screening, and then we're going to go for the conclusions. So to start, we're going to be presenting a short video from Mario Nava, that's the Director General from the DG Reform in the European Commission.
Dear Director Weiderpass, dear ministers, state secretaries, dear colleagues, dear ladies and gentlemen, good morning. I'm very pleased to welcome you to this event. The webinar will focus on the key results of our project supported by the Technical Support Instrument on improving cancer care coordination and screening in Latvia and Slovakia. Technical Support Instrument means tailor-made technical expertise to EU member states to design and implement reforms in different areas. Latvia and Slovakia requested technical support in the context of a growing burden of cancer cases across the EU. Unfortunately, we are all aware of that, as we have many been affected, either directly or indirectly, through friends or family members. This is why the project is so important. Over the past 2 years, we have worked together with you to improve cancer screening, registration, care, and research. We have adopted a comprehensive approach addressing all levels of cancer prevention and care. We did it with support measures very tailored to the local context, taking into account the specificities of the health system and the particular cancer burden. More precisely, in Latvia, we have provided recommendations to improve the governance and the organization of cancer screening and registration, including the IT system. We have also provided an action plan for establishing an accredited comprehensive cancer center, which would help to improve both cancer care and research. In Slovakia, we have focused on strengthening the quality of cancer screening, including alignment with international good practices. We have worked also on communication in order to strengthen awareness of cancer screening with a particular focus on citizens. Given the extension of the problem across Europe and the common challenges, we are delighted to have enabled the cross-country exchange to the mutual benefit of both member states and possibly other member states in the future. It's also important to note that this project took place in the context of many important initiatives on cancer at EU level, in particular Europe's Beating Cancer Plan and the Horizon Europe mission on cancer. Our technical support complements these initiatives. We work in close collaboration with the respective departments in the Commission, and many of the colleagues are here with us today, and I want to thank them. I want to thank also all those who have actively contributed to the success of this project through contribution in working groups, responses to surveys, and participation in past project events. I also want to thank the colleagues at the International Agency for Research on Cancer and the Organization of European Cancer Institutes. We have had a very productive collaboration with them, and they have provided excellent expertise and advice. We have already seen many promising developments over the course of the project, and I hope that the momentum persists and that you can build on the outputs of this project to tangibly improve cancer screening and care. Thank you very much for your attention.
Moving with the agenda, I would like now, it's my pleasure to invite Elizabeth Weiderpass, the Director of the International Agency for Research on Cancer, for her words. Please, Elizabeth.
Thank you, Dr. Carvalho. Dear colleagues, dear partners, dear friends, it's with great pleasure that I extend my warm greetings to each and every one of you on behalf of the International Agency for Research on Cancer of the World Health Organization, or IARC. Yesterday and today's event mark a significant milestone as we gather virtually to celebrate the culmination of the Improving Cancer Care Coordination and Screening in Latvia and Slovakia, ICCCS project, a collaborative initiative between IARC, the European Commission, and the dedicated Ministries of Health in Eastern Europe. The objective of the project, launched in 2022, rooted in this comprehensive framework, and has been to forge strategic plans and roadmaps in collaboration with our international partners aimed at significantly reducing cancer mortality in Latvia and Slovakia. This journey embarked upon with the commitment to advancing cancer control efforts aligns with the overarching vision of Europe's Beating Cancer Plan. After Latvia yesterday, today's event focuses on Slovakia. Cancer remains a significant health challenge in Slovakia. According to our estimates, in 2020, there were over 30,000 new cancer cases and over 16,000 cancer deaths in Slovakia. The incidence of cancer in Slovakia underscores the importance of strategic intervention and collaborative efforts to enhance cancer control and prevention. Over the course of this initiative, our collective focus has been on building the vital capacity for population-based cancer registration, enhancing information systems to identify and invite eligible individuals for screening, establishing robust frameworks for monitoring cancer screening programs, and aiding the Ministry of Health in preparation of a communication strategy for cancer screening. As we convene today, we are not just reflecting on the achievements of the project, but also setting the stage for a profound impact on cancer prevention and treatment in this region. The recommendations that will be presented by our experts during these events are not merely insights. They are invaluable resources that will guide authorities and stakeholders in fostering a more effective and coordinated approach towards cancer care. I would like to express my sincere gratitude to all the participants, experts in cancer screening, cancer registration, oncologists, policymakers, patient advocates, and researchers for your unwavering dedication and collaborative spirit throughout this endeavor. I would also like to thank DG Reform for their leadership and their generous financial support for this program. Your collective expertise and commitment have been instrumental in shaping the outcomes we celebrate today. In the spirit of shared commitment and continued collaboration, I welcome you to this occasion and look forward to the insightful discussions and recommendations that will propel us forwards in the ongoing pursuit of excellence in cancer care in Slovakia. Thank you very much, and I give the floor back to you, Dr. Carvalho. Thank you.
Dear Director Varda-Pais, thank you so much for your kind words. I'd like now to invite Michał Stawko, the State Secretary for the Ministry of Health in Slovakia, for his remarks.
Ladies and gentlemen, dear colleagues, first of all, I would like to thank you in the name of the government of the Slovak Republic, specifically the Ministry of Health, for letting me join you in such an important project and meeting, especially in the presence of such important experts and partners, as I can see in the floor. I won't speak long, just to be really say the important things. I'm looking especially at the outcomes of this project and in terms of looking at the registration of oncological diseases, increasing the awareness among population in terms of oncological diseases as well, and the screening programs, which are extremely important themes for a longer period of time, but specifically for this government. We also, just to highlight the importance of these themes, we have included these topics into the manifesto of the Slovakian government for the next 4 years. So we're really striving towards getting the job done, to be in like easy words. I'm really looking forward to receiving the recommendations from this group, and we will, in the name of Slovakian government, at least the Ministry of Health, I can assure you that we will do our best to implement the recommendations in the shortest possible time. So thank you very much.
Thank you so much for these words, and to reassure, the support that the Minister of Health will give for implementing the recommendations that's coming, because this was a collaborative action plan done together with the local experts. So thank you so much for, saying that the support is there from the Minister of Health. I'm going to give the floor back to Nadia for we continue with the agenda.
Yes, after this nice introduction and greetings, we move to the session on cancer registration. In Slovakia, the National Health Information Center is responsible for this activity. So I now invite Martina Rafayova to present the role of this organization regarding cancer registration. Martina, please.
Dobrý deň prajem. Chvíľočku, ja budem zdieľať prezentáciu. Vidíte, prosím vás, prezentáciu? Takže dobrý deň ešte raz. Dovolte, aby som vás aj ja pozdravila v mene Národného centra zdravotníckych informácií A v stručnosti by som vám predstavila vlastne Národný onkologický register Slovenskej republiky, jeho činnosť, to v podstate ako čo za posledné obdobie aj v spolupráci s vami sme riešili, dosiahli, kde sme sa posunuli a teda aké sú naše ďalšie plány. Národný onkologický register Slovenskej republiky je súčasťou národných zdravotných registrov, ktorých správcom je Národné centrum zdravotníckych informácií. Úlohou tohto registra je zber údajov, ich spracovanie, verifikácia, doplňanie, analýza dát, interpretácia a následné publikovanie výstupov. Národný onkologický register na Slovensku bol založený v roku 1976 a v Bratislave, pričom údaje v tomto registri sú spracovávané od roku 1968. Predmetom zberu a spracovania dát sú vybrané epidemiologické a klinické údaje o pacientoch s onkologickými ochoreniami a údaje o zomretých pacientoch s onkologickými ochoreniami. Príslušné spravodajské jednotky, respektíve poskytovatelia zdravotnej starostlivosti majú povinnosť hlásiť pacientov so zhubným nádorom do onkologického registra podľa platnej legislatívy na Slovensku, čo je aktuálne zákon číslo 153 z roku 2013 o Národnom zdravotnom informačnom systéme a o zmene a doplnení niektorých zákonov neskorších predpisov. A k tomu prislúcha vyhláška číslo 74 z roku 2014, ktorou sa stanovuje zoznam hlásení do národných zdravotných registrov, ich charakteristiky, podrobnosti o obsahu, podrobnosti o obsahu národných zdravotných registrov, postupe, metodách, okruhu spravodajských jednotiek a o lehotách hlásenia do národných zdravotných registrov. Od roku 2015, alebo teda, aby sme si trošku priblížili nejakú tú históriu, ktorá nám teda nejako nám privedie aj k tomu aktuálnemu stavu, ktorý v Národnom onkologickom registri teraz máme, tak od roku 2015 je umožnené zasielanie hlásení do Národného onkologického registra elektronicky. Do tohto obdobia to bolo umožnené len papierové hlásenia. A vlastne táto zmena prešla od roku 2015, kde bolo jedno hlásenie, ktoré obsahovalo všetky potrebné štruktúry dát do registra. V období rokov 2017 až 2022 boli elektronické hlásenia upravené, a to na 4 typy hlásení v závislosti od poskytovateľa zdravotnej starostlivosti, kde teda boli tieto hlásenia rozdelené na klinickú a epidemiologickú charakteristiku chorôb pre akýkoľvek typ špecialistu, ktorý diagnostikuje zhubný nádor, potom to bola nechirurgická liečba, chirurgická liečba, výkon a histopatologické, cytologické overenie ochorenia patológom. V priebehu roku 2022 vlastne v rámci projektu Dátová mapa, ktorý na Slovensku, alebo teda prebiehal v spolupráci s Ministerstvom zdravotníctva Slovenskej republiky, ale teda aj za spolupráci hlavných odborníkov odbornej verejnosti Národného onkologického inštitútu, prešla tieto hlásenia do Národného onkologického registra s zmenami, kde vlastne prebehlo alebo došlo k zníženiu počtu hlásení na 2 a súčasne sa vlastne zredukoval aj počet štruktúr, ktoré tieto hlásenia obsahujú. A vlastne tieto hlásenia sú platné od roku 2023 a teda sú platné aj pre aktuálny rok 2024, čiže zostali nezmenené s predchádzajúcim obdobím. Teraz by sme vlastne predstavili aktivity, ktoré sme realizovali v priebehu posledného obdobia. kde teda začali sme, alebo tak ako sme aj spomínali, nie je to úplne súčasť dátovej mapy, ale súčasť vlastne súbežne s dátovou mapou prebehli zmeny aj na Národnom centre zdravotníckych informácií, kedy sme v prvom kroku, koncom roku 2022, zmigrovali databázu údajov, ktoré sme mali z pôvodného informačného systému do nového informačného systému, ktorý aktuálne používame. Je to informačný systém zdravotníckych indikátorov. A vlastne tým pádom sme dostali vlastne databázu na jedno miesto, kde ten starý systém v podstate nespolupracoval s žiadnymi inými systémami, bol to ako keby uzavretý systém, nevedeli sme vlastne využívať nejaké iné zdroje k spracovaniu a vlastne k overovaniu zdrojov. To bola vlastne prvá fáza. Potom začiatkom roku 2023 sme začali finalizovať špecifikáciu a vlastne požiadaviek na tzv. Záznam zdravotného registra, kde sa vlastne kreovali všetky potrebné kroky, ktoré by sme chceli urobiť, aby sme vlastne zoptimalizovali a zefektívnili činnosť Národného onkologického registra. V priebehu 2. a 3. kvartálu prebehla testovanie prvej časti, ktoré vlastne pojednávalo, alebo teda sa testovalo spracovávanie papierových hlásení, ktoré ešte aktuálne máme, pretože sa boríme na Slovensku s tým, že teda máme ešte veľa prípadov, alebo je nám zasielaných veľa prípadov v papierovej forme a nie elektronicky. Takže toto bola tá prvá časť. V 3. a 4. kvartáli sme testovali túto druhú časť, kedy sa využívali elektronické hlásenia, ktoré sú nám zasielané do informačného systému. A v decembri minulého, ku koncu roku 2023 sa nám podarilo vlastne po úspešnom testovaní tieto všetky zmeny nasadiť do produkcie a teda začať v roku 2024 už využívať tieto funkcionality. Samozrejme, v tomto aktuálnom období hneď vlastne od začiatku roku sme začali sa aj teda s tým, že je to výrazná zmena vo využívaní informačného systému, tak sme pracovali a finalizovali s prípravou metodík a metodických usmernení pre pracovníkov, ktorí vlastne spracovajú tieto údaje a súčasne aktuálne prebiehajú školenia na využívanie, a teda aby sme vedeli pracovať v tomto systéme. Tie uvedené zmeny, ktoré som hovorila, alebo teda, že sme realizovali v tom minulom roku, tak by som vám chcela trošku priblížiť, že o čo ide v tomto rozvoji informačného systému. A je to vlastne systém, ktorý umožňuje zhromažďovanie všetkých zdrojov vlastne nachádzajúcich sa v aktuálne využívanom informačnom systéme na jednom mieste. A vlastne využívanie je podľa vopred stanovených a definovaných pravidiel, čiže sú to využívanie elektronických zdrojov, ako sú elektronické hlásenia, potom sú to v druhom kroku je to databáza vlastne hospitalizovaných pacientov, potom je to databáza úmrtí a súčasne ešte vlastne ako keby sprievodná dokumentácia, ktorú máme k identifikovaniu alebo teda k spracovaniu incidenčných prípadov v onkologickom registri. Tento systém umožňuje vlastne priame prepojenie elektronických zdrojov prostredníctvom identifikátora pacienta, v tomto prípade rodné číslo. Ďalej je to kodovanie výskytu sa všetkých typov, je to ako špecializované spracovanie, ktoré vykonávajú lekári Národného centra zdravotníckych informácií podľa teda platných medzinárodných smerníc. táto zmena nám priniesla aj vlastne, aby mala, teda očakávame, teda našim cieľom bolo znížiť administratívnu záťaž k spravodajským jednotkám a teda aj samotným zamestnancom Národného centra zdravotníckych informácií. A určite je tým prínosom aj rýchlejšie a zjednodušenie spracovania údajov, ktoré sa v tomto registri nachádzajú. V ďalšom kroku, alebo teda je tento systém umožňuje tento systém aj prepájanie tohto registra s inými zdravotnými registrami, čo vedie vlastne k rozšíreniu možnosti analýz a publikovania výstupov alebo spájania získaných údajov, ktoré máme aj teda z iných registrov, alebo teda nad tým robiť rôzne pohľady, analýzy a výstupy. Tu by som vám len ukázala vlastne tento slajd ukazuje to, čo bolo pred tým novembrom, kedy prebehla migrácia, kde teda zber týchto údajov prebiehal jedným spôsobom, teda to bola ten papierový zber, potom v podstate prebiehalo ako keby prepisovanie, kodovanie samostatne a potom vlastne doplňanie tých incidenčných prípadov nahadzovaním údajov, ktoré sme získali zase z papierovej podoby. A na tej pravej strane je teraz aktuálny stav, kedy je vlastne ten systém jednoduchší, pracujeme v jednom systéme a ten systém umožňuje to, čo už som teda vlastne v predchádzajúcej časti povedala. Čiže táto zmena, ktorú sme realizovali v informačnom systéme, vlastne priniesla výrazné zjednodušenie a optimalizáciu práce, aj teda, čo má určite vplyv aj na rýchlosť spracovania údajov alebo jednotlivých incidenčných rokov, pretože vieme, že ten stav na Slovensku určite nie je teraz vyhovujúci. Súbežne s tým, že sme vlastne urobili migráciu týchto dát, tak vlastne vznikla nová prezentačná vrstva údajov nad celým národným onkologickým registrom, kde vlastne vznikla infografika alebo tá interaktívna platforma, kde vlastne prezentujeme epidemiologickú situáciu onkologických ochorení na Slovensku na národnej a regionálnej úrovni. Je to na základe spracovaných údajov v tomto registri a je to teda je to vlastne spojenie všetkých rokov, ktoré máme, čiže od roku 1978 do roku 2014. Poskytujú vlastne tieto vizualizácie, alebo teda poskytujú vizualizácie výstupných údajov z tohto registra, kde nájdeme vlastne, bude to podľa absolútnych počtov prípadov. Ďalej vieme sa pozrieť na percentuálne zastúpenie a vlastne aj vizualizácie pohľadu epidemiologických ukazovateľov výskytu choroby, ako je incidencia a úmrtnosť. A teda výstupy sú ešte doplnené aj porovnávaním odhadov incidencie a úmrtnosti onkologických ochorení v medzinárodnom kontexte. Súčasťou infografík, ktoré sú vlastne k dispozícii na stránke Národného centra zdravotníckych informácií, tak ako som spomenula, sú už ukazovatele, vlastne sledované ukazovatele incidencie a úmrtnosti v triedení podľa jednotlivých krajov a okresov na Slovensku. Ďalej sú to aj ukazovatele vlastne podľa pohlavia, podľa vekových kategórií. A teda takú možnosť, je to naozaj vlastne infografika, ktorá umožňuje vlastne ten pohľad a možnosť vlastne vybrať si to, čo chceme sledovať, alebo to, čo nás zaujíma a v podstate interaktívne s touto platformou pracovať. Ďalšou časťou, ktorej sme sa v priebehu roku 2023 zaoberali, alebo ktorú sme riešili, je vlastne prezentovanie, alebo teda výpočet a následne teda prezentovanie tiež v interaktívnej podobe očakávané počty novodiagnostikovaných prípadov zhubných nádorov na Slovensku za obdobie rokov 2017 až 2021 v základnom triedení podľa skupín diagnóz a teda konkrétnych diagnóz MKH10, ďalej podľa pohlavia a vekových skupín. Na tento výpočet očakávaných novodiagnostikovaných zhubných nádorov boli použité údaje z dát od zdravotných poisťovní o uhradenej zdravotnej starostlivosti na základe vykázanej zdravotnej starostlivosti poskytnuté pacientom a údaje o úmrtiach obyvateľstva Slovenska, ktoré vlastne eviduje alebo štatistický úrad Slovenskej republiky. Čiže vlastne to bolo za to obdobie, ktoré teda neevidujeme ešte v Národnom onkologickom registri, ale je to naozaj, sú to očakávané incidenčné prípady, kde nie sú zaznamenané klinické údaje vlastne o týchto prípadoch. Ďalším z častí, ktorým sa venujeme, alebo teda ktoré rieši aj v zmysle platnej legislatívy 153, je tu screeningový register. Screeningový register, alebo aktuálne sa zaoberáme screeningom rakoviny prsníka, krčka maternice a vlastne kolorekta. A tento screeningový register je aktuálne v kreovaní, kde v spolupráci vlastne so všetkými zainteresovanými inštitúciami, teda ministerstvom zdravotníctvom, ale teda predovšetkým ministerstvom zdravotníctvom a Národným onkologickým inštitútom kreujeme vlastne tento screeningový register a teda, alebo teda hlavne KPI, ktoré nám budú vlastne, ktoré nám dávajú obraz, alebo teda ten výstup o tom, v akom stave, alebo teda tento screening na Slovensku je, kde tento register by mal obsahovať jednak je to identifikovaná cieľová populácia, potom sú to vlastne pozývanie na screening, ďalej sú to vlastne tieto screeningové testy, ďalšie doplňujúce vyšetrenia alebo nejaké hodnotenia, liečba a výsledky. Tieto vyššie uvedené údaje pozostávajú z podrobných premenných a vlastne sú zaznamenávané pre každú vlastne osobu individuálne, teda na individuálny identifikátor. A v podstate tieto údaje, ktoré by sme mali získavať, alebo zdrojom týchto údajov sú údaje zo zdravotných poisťovní predovšetkým a potom v ďalšom kroku sú to údaje o využívaní údajov, ktoré sa nachádzajú v e-zdraví na Slovensku. Ďalším krokom, alebo teda tuto sme sa snažili odprezentovať aktuálny stav, ktorý je teraz, a vlastne to obdobie, ktoré sme, alebo to, čo sme urobili za posledné obdobie v Národnom onkologickom registri. A samozrejme, tých plánov je o mnoho viac. Prioritou pre onkologický register je samozrejme zníženie sklezu spracovania incidenčných prípadov, kde aktuálne evidujeme spracované dáta za rok 2014. V roku 2024 máme v pláne, alebo teda aktuálne finalizujeme spracovanie rokov 2015 a 2016, ktoré sú teraz pred finalizáciou, alebo teda už by mali byť v priebehu priebehu roku 2024 publikované. A ďalej je to v podstate snaha o zverejnenie alebo teda o spracovanie údajov od roku 2007 podľa vlastne, alebo teda v systéme, ktorý sme prezentovali na začiatku prezentácie, a to je vlastne toho zdravotného záznamu registra, alebo teda využitím od roku 2017 vlastne tých dát, ktoré máme, tak budeme vlastne využívať v tomto už novom systéme, a teda budeme vedieť pracovať nielen rýchlejšie, ale teda budeme v tomto systéme vedieť vyhodnocovať alebo pracovať na viacerých rokoch súbežne, a teda očakávame, že alebo teda efektívnejšie alebo rýchlejšie zhodnotíme aj ostávajúce incidenčné roky. Ďalším cieľom, ktorý máme v tomto roku, je vlastne pripraviť ďalšie úpravy systému alebo teda špecifikáciou, ktorá by mala priniesť automatizáciu, digitalizáciu zberu údajov a opäť priniesť nejaké zníženie administratívnej záťaže pre spravodajské jednotky, kde máme ambíciu vlastne pokračovať vo rozvoji tohto automatizovaného zberu a spracovania štatistických údajov v prípade rozšírenia množiny štatistických výstupov. V roku 2024 sa vlastne zameriavame na, alebo chceli by sme k týmto zdrojom, ktoré elektronicky využívame, priniesť ďalší zdroj, a to v podstate využívať alebo začať využívať dáta, ktoré máme od zdravotných poisťovní a z dát e-zdravia, ktoré by teda v prvom kroku by nám údaje od zdravotných, alebo teda dávky od zdravotných poisťovní vedeli v systéme identifikovať incidenčné prípady, ktoré by sme ďalej vedeli spracovať za tú klinickú oblasť, a teda opäť by sme efektívne alebo rýchlejšie vedeli napredovať v spracovaní chýbajúcich rokov. Čiže v tej budúcnosti by sme predovšetkým sa chceli zamerať na využívanie týchto zdrojov, ako sú údaje alebo dávky od zdravotných poisťovní, e-zdravie a ďalšie zdroje alebo ďalšie systémy, ktoré máme k dispozícii, ale vlastne odkrokovanie alebo primárne by sme sa chceli zamerať teda na dávky od zdravotných poisťovní, ktoré by sme teda využívali aj v Národnom onkologickom registri. Čo sa týka screeningového registra, tam je v pláne vlastne prepojenie s Národným onkologickým registrom, a k tomu, že teraz využívame údaje na identifikáciu prípadov v screeningovom registri z dávok od zdravotných poisťovní, tak k tomuto pre tú ďalšiu časť kliniky a liečby vlastne zapojiť do toho aj údaje o e-zdravie, z e-zdravia, ktoré v podstate tieto údaje, ktoré sa nenachádzajú v dávkach od zdravotných poisťovní. Tu, tak ako sme pred chvíľou prezentovali to, kde sme sa posunuli od novembra 2022, tak tu by sme vlastne, tak je zhrnuté to, čo by sme chceli vlastne dosiahnuť v priebehu roku 2024, čiže aktuálny stav je na ľavej strane, a vlastne tá pravá časť znázorňuje to, kam by sme sa chceli dostať, a teda kde by sme chceli, alebo ktoré údaje, alebo ktoré zdroje elektronické by sme chceli zapojiť do Národného onkologického registra, a tým vlastne digitalizovať tento register v čo najväčšej miere, alebo teda s využitím tých dostupných elektronických zdrojov, ktoré máme, ale teda ich aktuálne ešte nemôžeme úplne v plnej miere využívať, Všetky tieto informácie, ktoré som vám povedala, ktoré sme teda, či už sú to výstupy z onkologického registra, alebo sú to očakávaný počet novodiagnostikovaných zhubných nádorov Slovenskej republiky, ale aj napríklad nukleárna medicína, klinická radiačná onkológia, sú publikované prostredníctvom štatistických výstupov na stránke nczi.sk.s. kde si vlastne nájdete podrobné informácie, či už o výstupoch, ktoré publikuje Národné centrum zdravotníckych informácií, ale teda aj o činnosti Národného onkologického registra. Ja by som v tejto chvíli poďakovala za pozornosť. Ďakujem veľmi pekne.
Thank you, Martina, for the details that you have provided about the cancer screening registry. We now continue with the presentation by Mario Shikeria on the recommendations for improvement of the cancer registry. Please, Mario.
Hello, everyone. I guess that you can hear me. First of all, I would like to express my thanks to IARC and the DG Reform for the opportunity to participate in this important project. I'm a cancer epidemiologist currently working as the head of population-based cancer registry in Croatia. There are many similarities between Croatia and Slovakia. So in brief, I'll try to present what I have learned during this project. So this is from literally a week ago from the LinkedIn webpage of the Eurostat. So some of the major characteristics of Slovakia for the occasion of the national holiday in Slovakia. So there are 5.4 million people, country of an area that's similar to my country, and some other important things to know about the Slovak Republic. As for the cancer-related data, there has been a report in 2023 by OECD for every country in the European Union. Some of the basic characteristics. Dr. Vajdek-Pask has already mentioned the estimates. These are the ECIS estimates from 2022, so around 16,000 new cases in men and 13.5 new cases in women. These are the estimates based on best available data. We'll come to that a bit later. So the third highest cancer mortality in European Union, but it is decreasing at a faster rate than in the EU as an average. Croatia is, as you can see, in a quite similar situation there. Regarding the cancer survival metrics from the latest Concord study, the survival is somewhat lower than in the other countries of the European Union for all cancers mentioned here, except for the childhood leukemia. When we look at the cancer care in Slovakia, in this graph from the same report, there is enough equipment, but the number of physicians is low compared to the European average, and the total cost of cancer was lower than in the EU average in 2018. So how do we know all this? So what is important to have when we discuss cancer data? Those are, of course, cancer registries. The traditional distinction is between population-based ones, so the ones covering an entire geographic area. Those can be in a region or an entire country. They can be general, or they can be specific for a certain age range, for childhood cancers, or for a certain type of cancer. The other type of cancers are hospital or clinical registries. They can also be general or site-specific. Here we are discussing about population-based cancer registries. This is a great graph from this publication describing which part of the cancer pathway the cancer registries are important. So we have them to assess the incidence of cancer and the survival of cancer at the population level. Recently, more and more, we are also speaking about the prevalence of cancer as a measure of trying to assess the cancer burden for a particular country. They are very important, so that, and it has been recognized through the European area. So in 1950, there were cancer registries in Denmark and Slovenia and in Hamburg, which was traditionally considered as one of the first. So this is the situation in 1970. In 1990, so the Slovakian one is already here. It was founded in 1976, as Martina has already mentioned. So, and this was the situation in 2017. Why is this important? So for the Slovak Cancer Registry, it was founded in the Oncology Center in Bratislava. It was relocated to the National Health Information Center after its foundation. It covers the entire country, so it's a national population-based cancer registry, and it is a member of relevant international associations of cancer registries. This is a graph from table from the website of the registry, indicating that for the cancer incidence in 5 continents, the most important publication of cancer data in the world, the Slovakian Cancer Registry has participated already in volume 4, and here it has been a participant until volume 10. Currently, it is a part of NHIC. It is a part of the Department of Registries and Data Collection with other health registries in the Slovak Republic. So what are the challenges? So what were we trying to assess during this project? So as mentioned, the Slovak data is in cancer incidence in 5 continents, volumes 4 to 10. But in the volume 11, it has been for only 3 years and not the all 5. And unfortunately, the data is missing from the CI 512. So there has been a quite significant delay in publishing of data. As Martin has mentioned, the latest report available is for 2014. There are different perspectives, of course, from the public health, from the policy view, and from the clinician perspective on what should and how should the cancer registry operate. And there has been at the level of the country a recognized need for data with high level of quality indicators, and the 4 typical, of course, the quality indicators for cancer registry as described in brain parking publications are comparability, completeness, validity, and timeliness. And timeliness is obviously something that's of an issue here. So what we tried to do and try to assess during this project is we had 2 site visits. So one of them, I had 2 site visits, and one of them was in June and one of them was in October 2023. There were meetings and briefings with relevant stakeholders from the National Health Information Center, from the National Oncology Institute, and from the Ministry of Health. And this has resulted in a preparation of a detailed report on cancer registration in Slovakia, along with recommendations on improvement of cancer registration practices, and also some recommendations on linkages between the cancer screening and cancer registry procedures and data sets. So we try to incorporate the views of all included partners, the needs of the stakeholders, reflecting different types and different parts of healthcare system, and to streamline them into a way that both the gaps that were mentioned can be completed in a reasonable way, and that the ongoing really inspiring way that the registry is moving forward, as Martina has mentioned, can be used in the best way possible. So briefly, I'll just go briefly through the recommendations. So and to assess what were our views on how should the registry proceed in the short term, in the medium term, and in the long term. So for the cancer registration, in the short term, so in the first half of the year, so there are 4 recommendations. The first 2 are to put into full operation the new information system Martina was speaking about, enabling linking all electronic sources for routine cancer registration processing. The second one was to update the standard operating manual of the NCR, so of the cancer registry. So for the people working at the NCR, to have a manual of procedures for consolidating data and creating incident cases in the new software. The next ones are setting the expected dates for the publication of data for 2015 and 2016, which are near the completion. So we've discussed that at the October meeting with the NHIC participants, and the agreed year and the agreed timetable was during 2024. And perhaps one of the most important recommendations is to create an advisory board of the cancer registry with all of the relevant stakeholders included, including clinicians, data experts, and policymakers. So this advisory board can then steer the registry and ensure that there are adequate resources with which the requirements that are put in front of the registry are being met. So these were the short-term recommendations. As for the medium term, so 6 to 24 months, there needs to be a plan for processing of data for 2017 to 2022. Martina has mentioned that there are estimates based on health insurance data, and those estimates are quite plausible from what we can see, but those estimates itself are not enough for participation in cancer incidence in 5 continents, in international survival studies, and so on. So the way to move forward with this data needs to be decided. There is a significant role of the advisory board there. So a decision needs to be made on the way to proceed. And from that decision, the number and the structure of registry personnel needed, including the decision on the acceptable levels of quality indicators, will need to be made. Related to this, the second recommendation is to try to separate the procedures of closing this gap until 2022 and registering the cases onwards, so completely in the new system, and to dedicate the staff and resources between these two tasks, because it will be difficult to try to do all this in parallel if the gap is to be closed in some acceptable time. So the third recommendation is the new way of collecting data will, of course, require some optimization of the legislation in terms of data collection, processing, and dissemination, and to link all of these new types of data sources for the health record in the registry, as Martina has described it, will be an important addition. So as for the long term, as mentioned, there were some recent studies and data collections that the registry has not participated in. This should be mitigated. On the participation should be renewed, and the next waves of CI5 and other studies should have Slovak participation. Then a creation of a training curriculum for the personnel of the cancer registry is warranted. There is a lot of material available online for the new persons starting to work at cancer registry. Those can be translated if needed. At some point, there will be a discussion on trying to define a possible expansion of data sets by particular cancer types, but I would strongly suggest that this should wait until those previous things are met. So this activity can be considered after the delay in data processing has been resolved and the delay is much lower. And of course, I do believe that the years to come will have, in the field of artificial intelligence, there will be advancements that could be possibly used for the process of cancer registration, not only in Slovak Republic, but elsewhere. And those should be monitored and included, if necessary, respecting of course, all of the legal precautions. So these were the recommendations for the cancer registration. Briefly, there are some just recommendations for screening and cancer registration linkages. So first, in the short term, to closely monitor the process of developing the technical specification for screening registry, having a participant, a representative of the NCR there, to ensure that the necessary personal data for linkage is available on all of the sources, so the linkage can go smoothly, to check the existing legislation for the possibilities of linking and sharing data. So it's not always sometimes straightforward what can be done and what should be done, and are there any other requirements that need to be met. For the medium term, again, to monitor the process of creating the screening registry, to adding the relevant fields and procedures for determining whether a cancer was diagnosed through the screening program, and to create the relevant procedures and define the indicators for evaluation of screening programs using the cancer registry data. In the long term, to regularly publish the reports with all these relevant cancer indicators, again, to monitor developments in the AI field, and to explore the possibilities of using other relevant sources of data, not only those that were previously mentioned, but also including socioeconomic, patient-generated, and other routine healthcare data for improving the insights for the cancer screening evaluation. So for this, with this in mind, I would once again like to thank everyone in the Slovak part for their warm welcome and hospitality to everyone from the NHIC, to all three of Martinas, to Gabriela, Katarina, to Vera, and Kamil, to Jana Maria and Sonia from the National Oncology Institute, and to Daniela from the Ministry of Health. So if I forgot anyone, I'm sorry. Thank you all.
Thank you, Mario. It seems the recommendations and the action steps are very clear, so the stakeholders should be ready to implement them right away. We move to the next session on cancer screening, and I now invite Andrea Carvalho to present work on this part. Andrea.
Yes, thank you again. Here we go again. I would like to start by thanking Martin and Mario for this work in the population-based cancer register, and also to showing some linkage right with the cancer screening register. I think this will be very important for the improvement of the screening in the country as well. I hope you can see my full page, right? So as a comment, this project is happening in Slovakia and in Latvia, right? In Slovakia, now we're going to talk about the cancer screening, the work we did in cancer screening, with, that was request for digitalization and data protection. This would include a lot of quality assurance. And the IARC team, you know, on our side, work on that was myself and Nadia Dimitrova, it is Lansdorp, Vojalar, and Carlos Signori. My thanks to the IARC team, and my huge thanks for all the stakeholders back in Slovakia that was participating in the part of the cancer screening. Right, we are talking about the work package 5 and work package 6. This is about, you know, quality improvement and the information system in Slovakia. So we are looking for the outputs as putting together during the project a strategic plan for cancer screening according to relevant EU guidelines and quality standards, and also recommendation for data collection tools, data flow, data access, and desirable linkage to the new integrated information system. That's what just we saw in the presentation from Martina and recommendations from Mario. We are expected, right, from the European Commission, and also our expectation from IARC is that based on what we're going to deliver as outputs, that the Slovakian government will take over and deliver the outcomes, meaning that the national authorities and key stakeholders will be committed, you know, to have the competence to implement the quality assurance cancer screening, and also the national authorities have been developed a tailored information system to monitor evaluation and improve the cancer screening program, and to support the population-based screening register. And we can see that, you know, movements and changes and implementation on that has been happened since the project started 2 years ago. When talking about improving the cancer screening, we evaluate main components like governance and legislation, screening, test, and diagnosis, mainly through the guidelines and protocols. How was the organization, funding, and the staff or workforce, the invitations, the communication with the screening participants, the raising awareness is going to be, you know, speaking later when we talk about the communication strategy. The data and the IT system, we saw a lot of that in the presentation before. Quality assurance and how can we integrate research. In the meantime, we IARC have been working on this of consensus about what is the main or the essential components for a screening cancer screening program to be highly organized, and we evaluate for the health system building blocks from leadership, governance, workforce, access to essential services, service delivery provision, and information system quality assurance, the 16 essential components for a highly organized population-based cancer screening program. And we also decided to see, how Slovakia would be organized using these framework as well. So how we got to the recommendations, we used mixed methods. We did a desk review looking for policies and governance, screening protocols, information system, and quality assurance. Was mainly based on policy analysis. We did facility visiting. We did some site visits to Slovakia, looking for the screening centers, trying to understand their diagnosis and treatment centers to see the health system readiness for the change, for the implementation. And also we interview the key informants or the key stakeholders. We had a meeting with the working groups to see the implementation climate. In the end, we took all that information and validate that with the local stakeholders and put together a SWOT analysis, trying to see how that would fit in what we have been evaluating regarding governance, the protocols, organization, and so on. We also, during this process, did a lot of stakeholder mapping process to understand, who are the stakeholders, what is the power influence assessment by understand the power dynamics, what are the stakeholders team creation to try to form this cohesive group to define their roles and resources, and the stakeholder involvement on planning, designing, implementing, and evaluating. In the end, we try to bring those stakeholders that we identify together, make them, engage together, also thinking about, who is involved in the political and policy making, factor screening, instill confidence that the program is for the public good, the program managers, the implementers, and the potential participants. With all that information, we put that together, the finds of the situation analysis, the SWOT, and to feed the action plan. And the action plan, again, was built together with the local stakeholders, then to take it into contact the local context. So action plan was presented to stakeholders in a team workshop, and this was a collaborative to try to find interventions elements that best fit the local context and interventions that might be different to suit that local context. And overall, we saw a few main bottlenecks in the process, right? Regarding the governance and legislation, regarding the organization, funding, and workforce, and regarding the data and IT system. The coordination, we have been trying to work together how that would best fit the Slovakia. We brought one model that was a simplified model that could, not the need of so many new hires. How can we do the best we could with the existing workforce in the governance, but these also would need to be adapted for the Slovakian context. And regarding the IT system and the pathway, we need to understand, how complex it is, the screening program compared, to other process in the healthcare. When we invite someone that's a health individual to get a test, and once the test is positive, how many steps they have and how we need to track that process. And this means, a lot of, transit of data, different healthcare services and healthcare providers inputting data that need to go to a centralized data, but also need to feedback, so there is a feedback, there is a control, because in the end of the day, we need to use that data for tracking the participants, and this in real time. Right, and this is one complexity that is very difficult to implement, but very necessary, because we presuppose that the possibilities are known, But we also need to understand that there's alternative possibilities, that the participant will not show up for screening tests, will not show up will not comply to the further assessment, will not yet be treated, or the diagnosis not reported, will not be evaluated, or even refuse to continue in the pathway. So we need to redesign the pathway, and we need to track the individual through this pathway. Moving on to what were our finds among the 16, essential elements for highly organized cancer screening program. 10 was implemented or partially implemented in Slovakia, but 6 was missing. This was, how the evidence protocol and guideline was universally, in compliance with the services delivered. How could the invitation system incorporate the call recall and then for non-compliant compliant individuals, to have an information system with appropriate linkages in a legal framework. And we just saw a presentation on that sense, but how also we could have a better quality improvement framework, and with a responsible team. We saw a lot of discussion in quality improvement in mammography settings, and for breast cancer, this is more advanced in Slovakia than with the other cancer screening sites. But also how, the reports can have better information about not only the indicators, but the reference standards and the goals, and about the audit. So this is, regarding the organization of the program as a whole. But also, we find some recommendations, breakdown for the teams that we evaluate. With that, our action plan would be developed, and part of that action plan is going to be presented by the local team just after my presentation. So in the governance and legislation, our recommendation was strengthen the governance structure for screening programs according to the proposal that we brought, with adaptation for the local context, expanding the cancer screening section in the National Cancer Control Plan, describing the governance structure, budget, and legislation framework for the screening program. Regarding the screening test and diagnose, our recommendations to prepare and endorse the most recent evidence-based guidelines for all cancer screening programs taking place in Slovakia. On the organization and funding and staff, is the preparation of a referral pathway between the different levels of care regarding the cancer screening continuum. I present a little bit, how that is complex, but how that is important to keep the compliance within the cancer screening continuum. How implementation of the training program and the plan and organized training courses for the cancer screening services provider. This was an addition that we did with the program. We gave some training also for some of the management of the cancer screening program in Slovakia on how they could develop better trainings for their providers, and some of proposals for the training came from that workshop, and we hope this could be implemented in Slovakia, but also define the budget dedicated to training of screening services providers. For invitation and communication, there was an invitation system in place. This was basically based on the insurance companies sending the invitation, but there was no call-recall system, and there was no fail-safe mechanism to make sure for the compliance for all the steps. So our recommendation, came how to strengthen the invitation system, how eventually to unify that and include on that a call recall and a fail-safe mechanism, but also, to prepare a written procedure for communication with the screening participants. So a better understand the importance, not only for the participation, but, what is the next steps once you are identified as with a positive test. What is your next step, and the importance to be compliant with that. On the data information system, the establishment of a screening register at the National Health Services, with possibility for a linkage with the population-based cancer register and eventually the clinical hospital-based register. We just saw a presentation that this is, ongoing, as well as the legal framework that comes together that allows not only that data linkage, but also the sharing of that data while ensuring the data protection standards. And regarding the quality assurance, is to create and implement a quality assurance scheme for the screening programs based on the existing EU quality assurance schemes, and define the budget for implementation of a quality assurance scheme for the screening and the program. One thing that when we were, finalized those recommendations is that we saw how similar most of those recommendations were for both countries, for Slovakia and for Latvia, but yet how different sometimes the solution and what needs to be implemented is different when we take into consideration the context, but also how one country could learn from another, for what they test and so on. So this was a good exchange. And finally, one thing that was missing in both countries, and here we're talking about Slovakia, is how to incorporate research into the screening program. How to get a strategy for it, and how to use methods of implementation science to facilitate the decision-making on improving the effectiveness of the cancer screening programs. We think that, once you have all the components in place and you begin to collect more and better data, you're going to have a lot of data. And incorporate research, you're going to have more people helping analyze the data, seeing the gaps, or seeing what's working and what's not working, and these come for our next round of quality improvement of the cancer screening programs. What are the highlights that we see on our side, in the discussion with the local team, of this project is, and also this was commented by the director of the DG Reform and the European Commission, that this is quite country specific. It's tailored for the local context, and I think this is a very important. That the local teams, providing data inputs and validation, the participation was a hands-on. They participated in the situation analysis, in the validation of that. They were there with us for the site visits. They did together the SWOT analysis and the validation of that, but also the collaborative development of the action plan and the roadmap. And I think this brings together, the importance of the stakeholder identification, engagement, and how, country towards the end of, the middle and the end of the project begin to have ownership of the project. This, I think, is the key of the success for the implementation of the recommendation. When part of the recommendation and the action plan comes from within the country and not only from the external experts. And finally, how the technical support instrument from DG Reform is a use of mechanisms for countries seeking for guidance on implement changes and evidence-based interventions at their cancer screening programs. Here, I'm going to finalize my presentation and give the floor back to Nadia. Thank you, Nadia.
Thank you, Andre. Very informative presentation, recommendation, and everything, but the picture would not be complete without hearing about the perspective of the local experts. So I would invite Jana Tratenberger-Rikuva to explain about their role in cancer screening in Slovakia. Jana, please.
Okay, hello everybody. Good afternoon. Before I will start the Good afternoon. Before I will start the summary presentation about the cancer screening in Slovakia, I would like to thank to be part of this excellent project and to cooperate with experts from IARC and other colleagues. Thank you very much. Please let me start. Let me start with a brief overview about the organization of screening programs in Slovakia. The law number 577 sets the rules for preventive checkups, including oncology screenings. And in May 2019, it was endorsed amendment of the rules of organized screening. where the Ministry of Health has their role as a national governance authority. National Oncology Institute is coordinator and evaluator. Professional organizations set up the standards and guidelines. Health insurance companies are responsible for invitation and reimbursement of screenings, and National Health Information Center has main role for data collection, processing, and provision.
Jana, sorry to interrupt. Would you please switch to presenter mode because we see only one slide at the moment?
Okay. Can you see now it works?
No, can you auto put in presenter mode?
Jana, would you like me to share the slides on your behalf? I have your copy.
Okay.
Jana?
Yes.
Yeah, so I share screen on your behalf.
Yeah, please.
Can anyone confirm if you see it?
Yeah, we can see, but not yet in
The screen mode, right? Is it okay?
yes, now yes.
Yeah.
Thank you.
Tell me if I have to move the slides, okay?
Please, okay. Next slide, please. Okay, the main governing body for cancer screening is Commission for Cancer Screening Programs at the Ministry of Health, and it serves as advisory body for Minister of Health. There are 6 working groups, and they consist from a mix of stakeholders from Ministry of Health, NOE, experts, etc. Next, please. Till 2019, opportunistic screening has been running in Slovakia. Currently, we are trying to implement organized screening, but some of requirements are not fully met. However, continuous improvement of existing oncology screening programs could change the status from partly organized to population-based screening program. Next. ICCCS, or Improving Cancer Care Coordination and Screening Project in Slovakia, took 2 years. Many meetings with specific tasks were held, and a lot of work was done. Please click 2 times. Click 2 times, please. Okay, next. At the beginning of it were defined 3 objectives. I will focus mostly on the first one. Please click. And the next. Okay. Now the experts from IARC submitted to Slovakia recommendations for 8 elements. And please let me go through 5 of them. Please click. And the next slide. Okay. As a first, and from our point of view, the most important related element is governance and legislation. I have used the picture from IARC recommendations because it perfectly displays the necessity to reorganize the structure of the screening programs management. And please click. We consider as the most important is to strengthen the governance structure for the screening program by new Ministry of Health leadership, to define main objectives of the cancer screening programs by health authorities, and to expand the cancer screening section in the National Cancer Control Plan with systemic and continuous funding. Next slide. Key actions resulting from IARC recommendations are legislatively strengthened screening commission competence to increase decision-making position, to set up legal status of National Oncology Institute as executive body for screening programs with transition to National Oncology Screening Center with given governance structure, legislative framework and budget, then prepare and endorse the law 153 update for the purpose of screening evaluation and update of the law 577 in line with cancer screening recommendations. Next, please. Out of 8 defined elements with relevant recommendations, I will focus now on next 4 of them related with 3 implemented screening. There is the screening test and diagnosis guidelines and protocols, organization, funding and staff, invitation and communication and quality assurance. Please next. So I start with a very short overview of breast cancer screening. Please next. So breast cancer screening program started in September 2019. Screening mammography is performed only in certified screening mammography centers. Currently in Slovakia is certified 23 working places, is intended for asymptomatic women in age 50 to 69 in time period every 2 years. Invitation is provided by health insurance companies, but only the women who have not attended mammography examination in the past 2 years are invited by health insurance companies. Also, mammography working places can invite repeatedly for screening, and also gynecologists and GPs can recommend for mammography screening. We can mention that also preventive mammography is performed in all certified mammography centers and currently exists approximately 70 working places. Please next. Now we can look at current status. So organized screening program is implemented. 23 high-level certified mammography screening working place are in this was in till 2023. There are existing working group for breast cancer screening, also existing expert working group of Ministry of Health for quality assurance of mammography working places. Then invitation partly by health insurance companies according published methodological instructions. Established MammoLive, what is clinical screening registry for collection of data for mammography screening working place on monthly basis. There is published the 3rd revision of the standard procedure for screening mammography, as well as for high-risk female population. There is published annual reports. And for breast cancer screening, there's strong NGO awareness activities. Next, please. Next, please. Following the IARC recommendations is needed to broaden the target age group of women till 45 and 7 to 75 years and remove breast ultrasound once in 2 years as a preventive examination for breast cancer. Then introduce centralized system for sending invitation with call and recall functions, reduce waiting time for mammography to acceptable level, increase the number of mammography screening centers to 35 and improve their coverage and availability to all women. Insurance capacity and budget for regular quality assurance, training for radiologists and other involved stakeholders, support and strengthen mammography screening program through the update of the law 577, and finally, continuous monitoring, reporting, updating of screening program. Next. We can now look at cervical cancer screening. Next. So this screening started in August 2021. It is used pap smear screening test performed by gynecologists during preventive gynecology checkups. is intended to women from 23 to 65 years old. In the screening interval 1 year, and if negative results every 3 years. And tests are evaluated by certified screening labs. Invitation also by health insurance companies, partly because only asymptomatic women who haven't attended the cytology examination in the past 3 years are invited, or gynecologists can invite repeatedly for screening. Please next. Also, current status, this screening is implemented. There is established working group, invitation partly by health insurance companies according published methodological instructions. We have certified screening labs who evaluate screening results, and abnormal cytology results evaluated by certified high-level expert colposcopists. There is published methodological instructions for reporting procedures and diagnosis for the health insurance companies. And experts, we achieved experts consensus for introductions of screening, new design, cytology every 3 years for women in age from 23 years, with HPV DNA test for women aged 35 and 45 instead of current screening interval 113 and cytology only. By the way, our experts were motivated by this project to achieve this agreement. So thank you. Next, please. So, and again, following the IR recommendations, is needed to introduce the recommended HPV test for cervical cancer screening after the necessary preparation and transition period, then implement HPV testing to the Slovak guidelines and adjust screening interval, then publish cost-effective analysis to improve importance of HPV screening program on governmental level, prepare screening program protocol with systematically organized paths of the screening participants and patients, strengthened coverage and availability of expert colposcopy working places, endorse methodology for expert colposcopy, support and strengthened cervical cancer screening program through the update of the law number 577, and finally, continuous awareness campaign, education of professionals and lay people reaching to hard-to-reach population. Next, please. And finally, we can look at colorectal cancer screening. Please, next. This screening started in October 2021 based on pilot in 2019. The fourth screening test is performed by GPs, followed up colonoscopy in case of positive test result. Is intended for the men and women in age 50 to 75 in every 2 years. The tests are evaluated by GPs or by certified screening labs. Invitation is provided by health insurance companies. Only asymptomatic men and women who haven't undergone FOBT in the last 2 years or colonoscopy in the last 10 years. As alternative is used primary screening colonoscopy every 10 years. Next, please. Again, we can look at current status. This screening is implemented. We have established working group for this screening. There is published standard procedure for colorectal cancer screening, also for high-risk population. Invitation partly by health insurance companies according to published methodological instructions. Also, opportunistic screening is performed by GPs. Follow-up colonoscopy in case of positive test results is provided, and primary screening colonoscopy every 10 years as alternative. And in Slovakia, we registered 152 certified screening gastroenterologists. Next, please. So, and finally, following the IR recommendation, is needed to introduce quantitative fit test with a unified cutoff, intensify cooperation of existing working group with greater emphasis on GPs, prepare and introduce a centralized invitation approach, describe the whole pathway of screening participations in patients, in other words, screening program protocol, strengthen availability and quality assurance of screening colonoscopy working places, and reduce waiting time for colonoscopy to acceptable level, accept painless colonoscopy as the standard with an adequate reimbursement, and support and strengthen colorectal cancer screening program through the update of the law 577. Please next. I started my presentation with objectives we set 2 years ago when ICCCS project began. Now we can see expected outcomes of the project, and one from the most important is that national authority and key stakeholders are committed and have the competence to implement quality assured cancer screening. And we hope that this excellent project helps really improve level of screening programs in Slovakia, and current leadership of Ministry of Health and relevant authorities will accept the recommendations from IARC experts as a commitment to their fulfillment. Next. And finally, we can ask why, what ICCCS project brought us. Firstly, excellent experience with international experts and friends during 2 years, thank you. Application of IARC recommendations to the National Action Plan for the implementation of population-based cancer screening program in Slovakia. And finally, a great opportunity for new Ministry of Health leadership and key stakeholders to reduce cancer mortality in Slovakia through the improvement of the cancer screening program. Next. Please let me wrap up my presentation with a powerful thought. We can have reasons or we can have results, but we can't have both. So we choose results. Thank you for your attention.
Thank you, Jana. We move directly to the next session because we are a little bit ahead of time. So Daniela, please. Daniela will tell us more about the communication strategy that was prepared for the screening program in Slovakia.
Yes, thank you. Kritika, due to technical reasons, could you please share also my presentation? Thank you.
Yeah, can someone confirm?
Yeah, perfect. Thank you. So, dear colleagues, I would like very briefly to talk about the communication for cancer screening from the country perspective. Next, please. Cancer is one of the major public health problems affecting our society. WHO Cancer Control Global Snapshot from the year 2015 report indicates that while 87% of countries have an existing policy or strategy or action plan for cancer, only 68% reported the plans were being implemented. So we are also aware of performance gaps in Slovakia, lack of continuity and limited evidence of effective implementation when we are talking about the national cancer plan. Controlling cancer in Slovakia will require the investment of substantial resources and the effective coordination at the national level. Next, please. The economic burden of current cancer is significant. Burden reflects healthcare spending as well as lost productivity due to morbidity and premature death from cancer. As cancer treatment costs increase, prevention and early detection efforts should become recognized as cost-effective and cost-saving. Please, next. Challenges and gaps in communication in Slovakia are low screening participation rates, low cancer screening awareness in general, and also low health literacy when we are talking about the health. We recognize a strong need for strategic approach to support screenings and motivation of the target groups for increasing the screening participation and cancer awareness in general in Slovakia. The requirement from the expert field was defined as a need for comprehensive communication strategy to promote awareness and participation in screening programs based on evidence instead of fragmented actions by different stakeholders, and this should be led by Ministry of Health. The next, please. Turning challenges into opportunities meant for us in 2020 that we asked through the Ministry of Finance technical support instrument request, and we asked for technical support, European Commission, to develop a tailored communication strategy for countrywide information campaigns on cancer prevention with focus on breast cancer, colorectal cancer, and cervix cancer. TSI project consultation and improvement has been done in 2021, and TSI project was launched in March 2022. Next, please. Cancer screening communication in Slovakia right now, our status quo. First meeting of the working group under the steering committee for oncology screenings for cancer screening communication start work in January 2022. OncoControlla campaign was launched in October 2022 by our former Minister Langvarský. Communication plan of OncoControlla was prepared in July 2023, and press conference with the introduction of new web animated spot was introduced in September 2023 under the leadership of the communication department from the Ministry of Health. Next, please. Our project aims in the area of cancer awareness, first, to sensitize stakeholders by country visits, by joint events and working groups. Communication strategy is a result of a comprehensive process and cooperation and teamwork with the aim to promote awareness of cancer screening services in Slovakia, and it was prepared in cooperation with Ministry of Health Working Group for Cancer Screening Communication. Now and today we have outputs for Slovakia. We have results of benchmark analysis and online survey about perceptions, motivations, and barriers related to cancer screenings in Slovakia, and we have prepared communication strategy. Next, please. My final remarks, and thank you to all of you, are focused on cancer prevention and control, that this should be and should remain our national priority. There is no prevention without communication strategy and health education. So it's time to act now for us in Slovakia in a team. And cancer screening programs need to be recognized as an investment with overall impact on social and economic development of Slovakia rather than a cost. I would like to thank you all our colleagues from IARC and all other experts and stakeholders working with us during the project. And I would like to give the floor to Clement, who will introduce and inform us in detail about communication outputs. Thank you.
Thank you, Daniela. Now we move to the final presentation in this session. Clement from IARC, Clement Chevet. Please, you have 10 minutes if you can fit in this time. Thank you.
Yeah, I try to make it as quick as possible. Can you see my presentation?
Yes, and it's not in presenting mode yet, Clement.
It's not in presenting mode, so just give me 1 second.
No, slideshow.
Is it okay?
Yes.
Okay, good. So, good afternoon, everyone. As Daniela was saying, so we work together on the communication strategy. The starting point, so Daniela explained it, so I won't dive into that too deep. I don't believe it's very useful. We know that there was a need in Slovakia to actually work on a comprehensive communication strategy when it comes to cancer screening. So what did we do for that? And this is to be honest, this is for me one of the most important parts. The first thing that we did in collaboration with the ministry was to try and understand what were actually the perception and barriers when it comes to the general population and especially to the target group that we wanted to reach regarding screening. And to do that, we actually split that part into 3 different phases. The first one was to organize a focus group.
Sorry to interrupt you. I don't know if just for me, but your audio is breaking, and I think it's your microphone, not your internet.
Sorry. Is it better like that?
I don't know. Can you try, because also the translators are
okay. So tell me if it works. Yeah. So as I was saying, the first thing we did was to organize focus group. We organized actually 6 different focus groups, 3 with men and 3 with women, in different Slovak regions, with the objective to understand really their attitude towards screening that could actually mirror what happened in the Slovak demography. And so when we understand better from the focus group, so this focus group were actually in-depth discussion with a lot of different people. Then from there, we knew which kind of a question we could ask. And then we organized an online survey, which was representative of the whole population in Slovakia, with more than 1,000 respondents for the online survey. And that helped us understand much better actually why people, what was the perception of people to screening. Yeah.
Sorry, your microphone, they are not being able to translate. Can you try to use directly the computer?
Is it better like that?
Is a little bit distant now.
Yeah. So I'll get closer to the mic. Perhaps you won't see me in the corner, but that's okay. Don't worry, I'm still there. As I was saying, we organized this online survey, and through the online survey, we were actually able to understand much better what were actually the perception and barrier that people had when it comes to screening. And then the last thing we did was to actually get with a lot of different key stakeholders from the Ministry of Health, but also from the health insurance company, from different experts, even from NGO and civil society organizations. We could understand from them, and directly from an in-depth interview with them, we could understand clearly exactly what was their attitude and what was missing as part of the communication strategy. So that we did that in Slovakia to understand better what was the situation for the Slovak population and the target. The second thing that we did was actually to do some kind of a benchmark analysis. So we did that in 5 different countries, mostly selected based on their regional population lifestyle, which was similar to the one in Slovakia. So we did that in the Czech Republic, Slovakia, Portugal, Denmark, and Ireland, where we actually deep dive into some of the awareness campaigns that were done in those countries and try to understand what were the key factors of success, the challenges that they face.
Clement, sorry,
yeah.
There are some, you still, now it's too low, so it's getting hard to understand and to have a translation. Sorry.
I'm sorry for that.
I think that your microphone is actually on your camera. Maybe if you talk in the direction of the camera, it might be easier to hear.
If I speak like that, it's okay? It's better?
Yes.
So I'll get directly the camera under my mouth. It might be easier. Can you hear me now?
Yes.
Okay. So as I was saying, the second part of what we did was the benchmark analysis to try and analyze what happened in other countries which had similar kind of a situation of the one of the Republic of Slovakia. And then the last one was also to work, and thanks to the coordination and the support of Daniela and the ministry, we work as well with the expert group that was already set up by the ministry. So we had a different set of discussion, and each time we are doing something, for example, on the barrier and perception survey, another, we were actually going back to the directly to the expert group to understand from them if there was, if they agree and if there was anything that they could complement. So this was the kind of the 3 axes of development we had. Again, first to try to understand better what happened in Slovakia. Second, to do some benchmark analysis to understand what happened in other countries similar to Slovakia and what were the key factor of success, and then to work directly with the expert group. And based on all that kind of input that we got from all these different stages, then we could define actually what were the strategy in terms of communication. And to do so, we actually defined the goal that we wanted to reach, being short-term goal, mid-term or long-term goal of what should be an awareness campaign when it comes to screening. We also defined the target group that we wanted to reach out to, and especially for all the three different cancer site and cancer screening programs, cervical, breast, and colorectal, and define specific target group. We define as well, based on those target group, we define the key messages and what we actually wanted to say to those target group. And then we define as well the different channel of communication we wanted to use and what were the different the messages we wanted to put together. So very quickly, and again, there is a very long document that everybody can have access to. We did it in a very comprehensive manner, but mostly that we, as I said, through the barrier and perception survey, we could understand much better what were the barrier when it comes to screening and the motivation for people to go to any kind of a screening program. So for sure, the idea that I feel healthy, I don't believe that I need to go through an exam because I'm not sick. The fear of possible illness or possible the fear of negative results, etc. So we analyze all that. We did the same with the expert as well, and understanding as well the expectation from the expert. One of the things that for sure coming from the expert, they understand the value of a screening program. But one of the things that they were saying, which was very interesting, it's the need to have some kind of a unified voice when it comes to a communication and an awareness campaign, not having the scattered kind of a messages, but something that can come from one institution. And there, this is where they were looking at the state and at the ministry to actually take the lead on that. So could provide making sure that there is some consistency and coherence, so it will have a greater impact. And the same from the benchmark analysis. We could see from the benchmark analysis the different channel of communication that they were using, ensuring as well that even the health insurance company were actually involved into the process, but also in terms of making sure that all this communication was clear and actually transparent, so we can build credibility to the program, because it should be a long-term program. It's not a one-shot, but making sure that people understand what could be the benefit for them in participating into a screening program. And so based on all this kind of input, there we could actually work on the communication strategy. Sorry. One of the things that we did, which was very important for us, that came up, and this is what Daniela explained actually, that came up mostly in the middle of the project. We understood there that the Onco-Controller campaign was already launched by the ministry at that time. It was launched mostly in October 2022, and then after that there was more communication material and then a website that was created and others. So the idea for us as part of our work, this is where, in collaboration and in discussion with the ministry, we didn't want to reinvent the wheel, and that was not the idea. So instead of doing a kind of a generic communication strategy, what we did was perhaps more to see how we could strengthen what was already launched by the government through the Onco-Controller campaign, and see how the recommendation that we're making could actually strengthen what the government was, what the ministry was doing, and making sure that at the end it will have even a greater impact. So this is what we worked on as well. So we defined a bit more about the way that the communication center, a one-stop shop kind of, could actually be designed and could be created, making sure that this is where there will be all the communication, certainly hosted by the National Oncology Institute, where there will be a web page where all the information and people could actually go to that web page. They could be tracked or pushed through that web page directly from different social media. We try to understand as well how we could work with different kind of media, being the general media as well, and the newspaper or the magazine, as much as with the social media today and with the influencer, for example, and even how we can disseminate information material through partners and especially through doctor office or different kind of event. Then we saw as well the role that, and we defined a bit more clearly the role that health insurance company could could have as well as trying to see for different kind of high-level partners. And then we deep dive into the different target audience. We define clearly the group of the target audience and the communication channel we're going to use with those target audience, as much as the messages and the key messages that we send. So as you will see that there are specific audience for specific screening program, like, for example, women age of 23 to 30 years old for the cervical screening one, the main age 50 plus for the colorectal one, etc. And for each of them, we actually define clearly the way we could reach out to them, the channel of communication we're going to use, as well as the different messages we should use with them to ensure better participation from them. And then we saw as well that there might be other target audience for us that are not the main target group, the one that we want them to participate in the program, but other target audience that could be very interesting and could actually be used as trigger and could share information with our main target audience. The regional self-government, for example, could have a clear role in terms of promoting the campaign, as much as the employer, the public health authority, or even the school when it comes to the awareness. And then at the end, as I was saying, we define the different steps where we see that it's a kind of a pathway for the patient to actually make sure that there is a stronger and strengthened buy-in for them into the program. So at first, the idea that they are aware of the program, and so how do they are aware through the media, social media, and which kind of message we want to pass on to them. And then they go from being aware to consider participating in the screening program, and then considering to actually decide that they want to participate. And then after they made the decision, so they're participating once, but it's not only once, it's to actually make sure that they comply with the rhythm and with the different steps of the program. That means that they go from one screening to another at specific interval. And then the last stage is that not only they comply, but actually they become an advocate. And this is for each and every one of these different steps that the target audience will actually follow, from being aware to becoming an advocate. We define exactly the kind of where the tools that we're going to use to make sure that the right message reach them, and then the kind of a message we want to make sure that they actually get to ensure more involvement and engagement from their part. And then the last part of what we did was also to try to design or define a bit more about the content that we want to use, with the idea that this content will be in different kind of a format, be it from infographic to visual to audiovisual, TV spot, or even YouTube or social media spot, as well as print and another kind of material. The fact that this material should be simple enough and should be in stage, if you want it. At first, we should be able to understand the information, and then this should go higher in terms of complexity. One of the things that we will advise strongly is to make sure that this communication material are developed as well with the target audience in mind, and that they are not done in isolation by some expert or even some agency, but they are done in a participatory manner to make sure that there is a clear understanding from the target audience. And the same in that this is the idea as well, and especially on social media, there are a lot of possibility to do a lot of testing today, where you can test different communication material to see the one that works best. And we will strongly advise, actually, when even through the OncoController campaign, to test different kind of communication material and messages, and make sure that you actually adopt the one that actually has the highest impact. And this one can actually be scaled up directly. We define also, just before getting to the last slide, we define also as part of the strategy, there was also some idea of what could be the monitoring framework, with some idea of the indicators to be followed to make sure that you can measure, and that the ministry will be able to measure the success of the awareness campaign that will be launched, as well as some kind of a risk communication strategy component as well, to make sure that if there is something that goes bad, the ministry will actually be prepared for it, and make sure that they will handle any kind of urgency or any kind of risk communication that may appear during the campaign. So all in all, the idea that what we feel will be very important is this idea of continuity and consistency, and that this is really, I do believe that this is where the ministry should take a leading role there to make sure that all the different stakeholders in Slovakia will speak with one voice and will have a coherent approach when it comes to promoting the screening program. So the idea of having an Onkonkotrola campaign with a brand name and then some logo and visuals, it's actually the first very good step. Right now it needs to be strengthened, and we need to clearly specify what should be the messages, and all the different stakeholders, including the health insurance company and civil society organization, should actually go back to the ministry and use the same kind of key messages to make sure that it will have a greater impact. Or everything should be done in transparency and clarity, and especially when it comes to the different messages, they should be very clear and transparent to ensure that there is more buying from the population as well. And when we speak about transparency, also is the idea of making sure that we communicate not only about the benefit of the screening program, but also, and because we know that there are some risk and harms, and to make sure that from the beginning there is transparency on that, and we can communicate about what could be the risk of any kind of screening program. And then to make sure we do that with a very human approach with a lot of credibility. So they're making sure that we engage with a wide range of supporters, and especially with the target audience, that everything is done in a participatory manner will help quite a lot in bringing that credibility. And then last but not least, to make sure that we do that in a multi-channel approach. Right? It's not only through traditional media, but making sure that there is from traditional media to the non-traditional one of the social media, but as well with different partners involving doctors and health insurance company and others. Thank you very much, and I'll be available for any kind of question you might.
Thank you, Clement. Despite some technical challenges, we believe the key messages have been delivered successfully. We would like to give the opportunity now to the core team from Slovakia for some concluding words. Daniela, please.
Thank you. We would like to thank you all colleagues from IARC and also other experts and consultants. I think those 2 years has been very productive and valuable for the Slovakia. And during the discussion, we found out many important perspectives we didn't see before. So I hope that we are just prepared in the right time for the implementation. Thank you to all of you. Over to Maria.
Yeah, so thank you also for the opportunity to say a few words at the conclusion of the project. I have to say that I think that the project was a great opportunity and privilege for Slovakia to work with international experts and to get their insights into the situation that we have in Slovakia and give us recommendations that we think are very important basis for work. We understand that the work doesn't end with the end of the project, but it's actually beginning of some changes, maybe implementation of hopefully all the recommendations. And I would like to stress also the importance of the 2 countries to be involved in such a project, because we could see that also Latvia had very similar challenges in their country, and based on their work, we could also be inspired how they were facing their challenges and what they were doing through the project and what are their goals. So thank you very much really for having the possibility to be a part of the project, and great thanks, of course, European Commission, DG Reform, IARC, but also all the stakeholders in Slovakia that were included in the project. So big thank to everybody.
Thank you, Maria. We are very grateful also for the valuable support from our consultants, Iris Lansdorf-Vogelar and Carlos Enore. Iris, would you like to share some quick thoughts?
Yes, thank you, Nadia, and thank you all from the Slovakian team for this experience the past 2 years. I've really enjoyed working on the project, and I was very pleased to see the Slovakian team exchange ideas and experiences at the Utopia East meeting, and I think that's also the way forward. So although the project formally ends now, I just want to say that if there's anything that we can help with from our side, please don't hesitate to reach out, and we'll be happy to help in the future. Thanks again to be part of this very nice project.
Thank you, Iris. Carlo?
Thank you, Nadia. I join Iris in thanking all the Slovakian teams, Daniela, Jana, and Maria for organizing our visit, for following us during the activity during the past 2 years, but also to all the health professionals we met during the visit. They showed a very collaborative attitude. It was a nice opportunity to share and discuss experiences about problems which are common to several screening programs, also to our screening program. So it was a great opportunity to interact and exchange experience. I think, as Iris was mentioning, that will be other opportunities in the future to go on in collaborating and developing the interaction and to support the development of screening in our countries, for example, in monitoring activity in the next joint action at the European level. So thank you again, and it was a great opportunity to work with you, and I think that will be other opportunities to continue this collaboration. Thank you.
Indeed, we will continue collaborating. Thank you, Carlo. Simon Dresi from DG Reform is also with us today. Simon, would you like to say some concluding words?
Sure, thanks, Nadia. So yeah, as the responsible policy officer for this project, I would also like to thank especially Daniela, Maria, and Jana for applying for this project and for their trust in us. I think Andre put it very well that local ownership, of course, is key, and you were always there, and you opened all the doors that were necessary for the experts to do a good job. I also want to say that, of course, all the stakeholders in Slovakia know that it was not always the easiest environment, with a lot of political changes over the past 3 years. And so I want to commend you for your resilience. And of course, we as the funding entity are very interested to see what will happen with the results. And we are very interested in the sustainability of the support that we deliver. So we'll follow the further developments with great interest. Thank you very much.
Andre, would you like to finish the meeting?
Yes. Yep. So once again, it's kind of, this is an important day for me, and I guess for everyone involved in the project as it gets to a conclusion. But as a comment, this is a conclusion of this project, but not a conclusion or a finishing of our interaction with the people in Slovakia and the stakeholders there regarding the cancer screening. We have other projects that are going to start, that are going to be involved, like the joint action. Right, so there are going to be a lot of opportunities for us, not only to interact with other projects, but also to follow up on this one that I have much interest on, right? But also we know that from the Slovakia stakeholders, even for this project, there is a lot of work that's going to start now by implementing the action plan. When we start the country starts a request for the G reform, important matter, and the shortfalls have been identified. So some of the changes and improvements have been already, in place or ongoing when we start the project, but not all the necessary. So I hope, when I see it was fulfilling for me that many changes already started that was based on what we saw in the discussion we had and what we constructed together, as we saw here today in the presentation. And so I like to see this project as a catalyst, as a facilitator, that the outcomes and the impact of the project can be achieved. And to finalize, once again, thank you for the Slovakian team, for the pleasant experience that we had when we visit the country, for those today here presenting and representing the work for all the stakeholders in Slovakia that participate in the project, and for the Minister of Health State Secretary of Slovakia, Marcus Istokov, that, reassuming the commitment of the Minister of Health to implement the recommendation of this project. Thank you so much.
Thank you. Bye.